My name is Elsa Shapiro. I am professor at the University of Minnesota in the departments of pediatrics, neurology, and also in psychology. I am a trained pediatric neuropsychologist and have been working in the field of neurodegenerative diseases for decades. I have partially retired from the University of Minnesota and now provide consultation to industry on cognitive endpoints and also behavioral endpoints for clinical trials. The historic challenges in measuring neurocognition in children with neurodegenerative diseases are many, but the first one was, how do you measure a child's development with a disease that alters their rate of development? In adults, you measure from a known level of performance and they lose function. Children are a moving target, and what you have to do is to measure their development and see then how a treatment alters that development. So that's the first of the challenges. The second of the challenges has to do with the tests themselves. Many of the tests do not measure very well the very impaired and the very young child. And so alternate ways of measuring those children's development had to be devised. And the tests that are normally available don't go low enough. They don't, and so we had to use tests that were geared for younger children in older children. Another challenge was that these children presented with so many other difficulties. They had motor difficulties, they had hearing impairment, they had visual problems, they were easily fatigued. And usually when you're doing a clinical assessment of these children, you can parse this out very easily by giving multiple different tests. However, in a clinical trial, what you need to do is to focus only on one aspect. You can't measure everything. And so you have to define what it is that you're measuring and find a test that is going to measure that aspect. Other challenges, behavioral challenges. For MPS II and MPS III, there are major behavioral challenges, and psychologists who give these tests are not usually familiar with these clinical phenotypes. There are no undisputed measures that cut across all disease phenotypes. It depends on the age of the child, it depends on the MPS disorder. There is no one single measure that can be used for all children who have MPS disorders. Age equivalent scores are a way of looking at whether the child is acquiring new skills, whether they are staying at the same level over time, or whether they're declining. And in order to figure that out, you have to take that test and use it in a natural history study in order to get these points at which the child begins to plateau or when they begin to decline. It is more difficult to measure cognition in children who are very impaired and for children who are behaviorally abnormal and for children who are very young. So those are three different groups. For the very, very impaired children, as I said before, you have to use tests that are geared for younger children and use age equivalent scores in order to manage that. For children who are very, very young, again, it's a question of waiting to see what the natural course of the disease is and what the treatment might be. For the child who's behaviorally impaired, there you need to make sure that your raters or psychologists who are doing the clinical trial are well trained and know how to handle these behavioral problems. One of the challenges in a clinical trial is determining how you select a metric, that is, a way of measuring outcomes from any one of the neurocognitive tests that are available. And there are three choices. One is you can compare the child to normative data, but the problem with that is that the normative data doesn't go low enough. And so you can't determine whether the child is declining or plateauing or improving because their IQ may be going down, but they may be at a plateau. Another way of looking at it is age equivalent scores, which I talked about previously. And age equivalent scores are a way of looking at the child's developmental progress, and that is an excellent way of looking at very young children or very impaired children. And you can look at that in terms of, are they acquiring skills, staying at the same level, or declining? And then the third way is to do a ratio of their age equivalent scores to their chronological age, and that's called a developmental quotient. And that is an important way of looking at whether there is a change in very impaired children, particularly, and it's sort of a comparison to an IQ. And so that is another way of looking at it. And so in constructing a clinical trial, the sponsor of the trial has to decide which of those particular measures they want to use and which would be the most sensitive to change with treatment. Well, the typical pattern of cognitive decline in MPS II is quite a bit different than MPS I and MPS III, which are better defined in many ways. The patterns are more consistent and less variable than MPS II. The challenge in MPS II is that we can't predict which children are going to have the neuronopathic form of MPS II. That is the neurodegenerative form of the disease. And you can somewhat predict using mutation analysis, but it's not very accurate, and there are many what are called private mutations, which people don't know whether they're the neuronopathic or the non-neuronopathic form of the disease. The other issue with MPS II is that there is a long period of what is called a plateau period in the decline of these children with the neuronopathic form. That is, they stay for a very long period of time at a level that is stable, but very, very low. And so that is quite different than you see in MPS I and III, which are the natural comparators to MPS II. The other issue in MPS II is hearing loss. And so hearing loss is a huge factor in MPS II, and it interferes with the neurocognitive testing that is done whenever there are language-related measures. So when we have assessed children with MPS II who have the neuronopathic form, the nonverbal tests do a better job in assessing the cognitive decline of these children. Their language declines before their nonverbal abilities because of hearing loss, and you can't always tell whether it's related to the hearing loss or to the disease itself. The design of clinical trials for MPS II needs to take into consideration a few factors. One factor that is very important is the hearing impairment. And tests need to be chosen that are nonverbal in nature. The other factor has to do with the length of the trial. And the trial needs to continue for quite a while because of that stability in order to ensure that you're actually seeing stability rather than decline. And then the final thing has to do with behavior. Again, designing a clinical trial for MPS II involves understanding the behavior. Parents would like us to be able to, they would like to be able to decrease those behavioral challenges because it interferes with their quality of life and the family's quality of life. And some parents would be satisfied with just ameliorating the behavioral problems in those children. The results on the cognitive testing may differ from what the parent sees because of several different factors. One factor may be behavior, and that the parent sees an improvement in behavior and the behavior isn't reflected on the cognitive testing. That might be one explanation. Another explanation is that the cognitive tests are often very complex, and there are many components. And the parent may see an improvement in one area, and the test may reflect that same area, but other areas may not be improving, and so in the overall score, it doesn't show up. And so there's a discrepancy between what the parent sees and what the cognitive test as a whole may show, even though there's a component that may improve. And the parent will fixate on that, of course. It's a natural thing to do, and then the clinical trial doesn't show that same result.